Hey, I'm Greg Witcher. I'm one of the emergency medicine residents. We're here talking with Dr. Eric Stern about non-accidental trauma and child abuse. Eric Stern is a pediatric emergency physician at El Paso Children's. He trained in Philadelphia before coming to El Paso. He worked in Temple, Texas at Baylor Scott and White. He's relatively new to our hospital, so we're really excited to have him here today to talk about this very difficult topic, but one that we have to know as emergency physicians. Let me just start off by asking you just like a terminology question. Does it matter if we call this child abuse or non-accidental trauma?
For charting purpose, I don't care what you call it when we're chatting. For charting purposes, I think calling it NAT is probably the right thing to do.
Okay.
And in some ways, like child abuse and neglect is actually the term I prefer most, because in this sort of genre of problems that we see, probably 60% or so of cases that you'll see will not have any trauma involved. They're cases of neglect. And so, like we focus a lot, and when we talk about it, whatever, for obvious reasons, because there's more medically interesting or whatever on traumatic injuries, but the majority of times that you're going to have to call CPS or something like that is going to be for neglect.
Okay. I've heard there's a strong association between abuse and military patients. Is that a useful idea for clinical care?
So I'm just curious where you heard it, or if you had experience with it, or exactly. I just liked it. It was interesting. That was the first question on your slide deck, and I just wanted to know where it came from.
Word of mouth.
Yeah.
I've read it in the literature, and but also seen it in real clinical practice.
I like it because it's a controversial question.
Okay.
Maybe not medically, but sort of politically controversial question. And I sort of profoundly dislike the stigma that kind of comes with the question, and the fact, because there's no doubt that word of mouth for sure, you're going to hear that all the time, and I'm like the least militaristic human you could imagine or whatever, but for some reason in my career, I worked locums at an Army hospital in between gigs way back. And then my career mainly has been spent either in Temple, which is right by Fort Hood. So we had an enormous military population there. And then now I'm here with another enormous military population. And so the answer is yes. That it is true that there is an association there. But I think it's like extremely important to separate it out, because the real association is families under stress, right? So, sorry, stop. Families under stress. So I have to say, I enjoy taking care of military patients and families a ton, and sometimes I'm probably surprised that there isn't more abuse and neglect because of the amount of stress that they're under. So especially like in residency and all that, and then even afterwards, we were still heavily involved in Iraq and Afghanistan, and you had families where one of the partners, or sometimes both partners, are deployed for like a year or 9 months or some ridiculous amount of time. They're often, especially for enlisted patients, very young parents who probably don't have a ton of frustration tolerance built up yet. I don't know if I have a ton of frustration tolerance, but that's why I just have dogs. And so it is true to think about the fact that military families are under a great deal of stress for many reasons, including deployments, age, PTSD problems, all of that business. Mm-hmm. But at the same time, when you think about it, or if you work in a big military town like this, I just think it's super important to separate it out. In my experience, anytime I've had a problem with a military dependent, the response of the military sort of they don't have like a military CPS, but the military investigators and the first sergeants and sort of the military response to concerns about child abuse and neglect are night and day with any response that you can expect from sort of civilian agencies. So if you get a case where you're suspecting abuse or neglect, like personally, if I know that they're active duty or whatever, uh, obviously we still report everything to CPS, but usually my first call, honestly, is to like their first sergeant, because I find that making sure the kid has a safe place to go, or finding like someone to take care of them, or and just the response is so much better from the military. So I think that when you take care of a military kid, you should avail yourself of resources there that you don't have necessarily with civilian patients.
That's really helpful. I like the more empathic approach about thinking of it as families under stress instead of lumping them into military or not, and then taking into account that you have other resources for these men and women in uniform that really can help a lot.
And I think families under stress is my overarching theme of what to think about with NAT or whatever, because like 95+% of child abuse or neglect that you're going to see is not like weird, sick, perverted sociopath people or whatever. The majority of it is going to be frustration abuse. So, parents are tired, the kid won't stop crying, maybe they were raised in this manner, and they grew up with abuse or neglect, or at least it was normalized in their environment, So, there is a certain small percent of like, cases that you'll see that are super perverted and bizarre and, with vile humans or whatever, but the majority of cases that you see won't be.
Right. Yeah, I can see that being important for how we take care of these patients, because we will be interacting with the not only the patient but their parents throughout the whole experience in the ED. And so to be a little less black and white about them being evil or not, I think helps make that interaction more professional and
have whatever emotional reaction you want, to it. I'm not saying you're not going to have feelings or whatever about.
No, of course, yeah.
But I just find it it's just like with a code, when you're running a code, it's not helpful running a code to get emotionally involved with the patient or the family situation, or how sad it is, or who this person was before they came into your ER. Just focusing on technical things, I think, allows you to get better care, and you can have whatever emotional response you want to afterwards. But I think it's the same thing with taking care of kids who've been abused or neglected.
Yeah, I could see the parallels there for sure. All right, well, that's a perfect way to start this conversation. I think we set the tone for this, because as I said, it's really difficult. How do you separate yourself as the physician from what police need to do and what CPS needs to do? I think for some of us who come into this profession, we think that, we're going to get to the bottom of it and we're going to solve it. And you can read in Rosen's or Tintinelli that you won't necessarily even be sure that there was child abuse. Your job is just to medically do a focused assessment and report what you find.
That's right. And I remember, like, I'm a doctor, I'm not a cop, for many reasons. I'm not a cop, and it's not my job to figure out who did what. So I think the biggest thing when you're taking care of a kid who you're concerned about abuse or neglect is to remember your role, and our role is to make sure the kid is safe. That's it. It doesn't matter if mom did it or dad did it or the babysitter did it or whatever. Who cares? Our job, other people care. It's not my job to care about that.
Yeah.
My job is to make sure like the kid is medically safe and that they have a safe place to go. So I'm a little bit of a hypocrite because I was saying, don't get emotionally involved. You're not a cop or whatever. I will say the one place that I tend to get angry in these cases is dealing with CPS,
Okay.
because our job is to make sure the kid is safe. Theoretically, that's their job, and there are some CPS workers who are great. A couple. There are a majority of CPS workers who are super stressed as well, and they don't have time, and they make like no money, and they don't not supported by their supervisors, and that sometimes they come up with these decisions about how they're going to keep whatever kid you're worried about safe for now, or plans for them to go home or whatever, and you look at what they've come up with, and you just think, what were you smoking, you crazy person? I mean, honestly, like it is absolutely moronic sometimes. And so that's the situation in which I do get angry in these cases. And sometimes a little righteous anger might be okay, because like I said, I'm not a cop, but my job is to make sure the kid is safe. And so that's probably why I fight with CPS more than anybody. I don't fight with parents or cops or whatever usually. I just fight with CPS because I feel like we often work at not necessarily cross purposes, but sometimes sometimes cross purposes.
Good to be forewarned about that.
Forgive me, anybody watching whose family is a CPS worker. I'm sure they're wonderful.
What do you think the role of intuition or gestalt is for these cases? A lot of us get a feeling. Do you find that's helpful or misleading? And how do you let that change your clinical decision making?
I think that you have to have a feeling or an intuition or a gestalt. And, intuition hopefully is based on experience and common sense, And so the most important thing with child abuse and neglect is to suspect it. And that's the hardest part. And unfortunately, like I can think of a case here in El Paso recently where there was a infant who came in that I had saw. They were a twin, and one of the twins was in the NICU, and the other twin had been sent home. And the parent brought the twin in with a complaint that they had vomited blood at home once, and and it was a baby. And most of the time, vomiting blood in babies, it obviously can be a big emergency if there's something horrific going on. But I say most of the time it's going to be from breastfeeding or something benign. So we worked the kid up, we watched them, whatever. The kid was fine. I ended up sending them home, and maybe a month later or something, the twin who had been sent home from the NICU came into the ER separately with one of the parents and was found to have like a subdural and multiple fractures and whatever else. And then I came back on shift, and the twin that I had seen weeks and weeks before came in and had a couple healing fractures or whatever also. So, I've been doing this a while now, and I still completely, the parents seemed reasonable. They had just gone home from the NICU. I didn't suspect anything. So intuition can lead you astray, obviously, sometimes. And then you may have a gestalt feeling about a story or a situation or whatever, but you just need to make sure you reality check it, and I think we're pretty good about that. But, just because you see like a spiral fracture or something doesn't mean that this parent is guilty.
Mm-hmm, mm-hmm. I think as a trainee, that's more what I worry about is being overly sensitive to something and then causing undue trauma to a family because I've accused them of something that my intuition or maybe my kind of like textbook reading misled me towards.
I think that is extremely common feeling. There are just a couple buzzwords there that so you said about accusing and worrying about creating trauma to the family. And like those are all things that we all naturally would worry about. Over time, though, I think you can kind of get used to the idea that, you know what, I'm not actually accusing you of anything. I'm not. Like I said, I'm not a cop. I'm just saying there's something weird here, and I have a legal duty and like a moral duty to make sure that it's okay. You know, and in my experience, the vast majority of the time, when you just are upfront with parents about it and are just like, listen, I'm not saying you did anything. I'm not even saying there's abuse or whatever. I just have to work it up because I have to. Most parents, I mean, they're not, you know, it's not the happiest day of their life, but I think most people are pretty understanding if you're just straight up about it.
Well, okay, so one of the questions I was going to pose to you later is how do you share your concern with parents?
So, like I said, I try to be straight up about it. You know, I think the question on your slide deck was like if you're going to get a skeletal survey, you know, what do you tell the parents or?
Yeah.
And I think it's super. I don't think it's very difficult actually at all. I usually tell the parent, hey, listen, we found this fracture, or they're concerned about bruising. So, you know, usually you get a skeletal survey after you find another injury most of the time, or, you know, something else, weird bruising. You just say, you know, this is there, and we need to make sure there are no other fractures involved to make sure the kid's okay and everything. Like, I mean, I think you can make it into a big deal, but if you're just fairly chill about it and honest and straight up about it, I honestly, I don't. There are obviously exceptions, but most of the time, I don't have a ton of problem with it.
So I know we're talking kind of generally here, and this is all case by case. There's cases that are slam dunks. There's cases that are really only a slight inclination. So would you say in general, you're going to get a skeletal survey without even mentioning your concern for NA to the parents? Or do you think that it's better to say you're doing this for a certain reason? I mean, I could see that you could get the skeletal survey, say, you know, I'm just looking for any other injuries that might have occurred. We sometimes see this with other injuries. Or you could say, you know, this is really suspicious. I think we need to consider that this could be an injury inflicted by someone onto this patient.
I mean, eventually I will have that conversation. Usually I'll have that conversation if I do a skeletal survey and I see a bunch of fractures or there are multiple injuries. So usually my first conversation is just like, hey, we found this injury. I need to make sure there's not a bunch of other stuff. This is what I need to do. And then if I find stuff, then I do think it is important to tell the parents, again, not like you abused your kid. I know it, but like, I'm concerned this is not, I usually will say like, there are multiple injuries here. This is most consistent with like somebody intentionally or accidentally or multiple times doing this, and then I tell them that I need to call CPS and whoever else, because I think it's a bad idea to spring that on people, like the parents' first like inkling that CPS or somebody else is going to get involved is when the CPS worker walks through the door. That usually goes poorly.
Yeah. Okay.
So a little heads up is good.
Cool. Okay, that makes a lot of sense. So I want to make a plug for the 10 for Faces mnemonic now. It was originally in a 2009 pediatrics article, and the way the 10 for Faces mnemonic goes is you should suspect abuse when there's bruising of the torso, ears, or neck. And then also if you see any bruising of the frenulum, angle of the mandible, cheek, eyelid, or sclera. So that's 10 for Faces.
I think that's a very good mnemonic. I quite like it. And it's location centric. The other thing that I would mention is also bruising pattern. So when I was learning about child abuse and neglect or whatever, someone much smarter than myself said that God doesn't make right angles. So and that's true. So bruising usually isn't linear, perfectly linear, or have significant angularity to it. So if you see something like that, it's unusual. There are some good sort of pictorial references for classic patterns, like, cigarette burns or stuff like that. But in general, I think it's helpful to think about what occurs in nature, and then all of this, you have to tie whatever story you're hearing to the injury pattern you see and the developmental status of the kid, and see how those things fit together and whether they do or they don't. So I think we were talking the other day about a little bit about developmental stuff, and like I said, you don't need to know how many boxes you can stack or whatever like that, but a couple developmental milestones that have in your head ages for is helpful. So like we said, social smile, front to back, turning over, back to front, crawling, walking, couple words. I mean, that's pretty much all you need to have in your head in order to for our job. If you can fit those together in your head with whatever story you're hearing and whatever injury pattern you're seeing, then you're way ahead of the game. The other thing, like I said before, is that, like I said, the majority of this stuff that you're going to deal with is actually neglect. And so developmental milestones are good to have in your head for neglect. If you have a 2-year-old who's not saying any words, that's very abnormal. And if they have not been worked up for that, you need to figure out why. Have they been to the doctor? What's going on? Why aren't they talking? Does anyone talk to this kid, or they just, are they locked in a closet all day or whatever? You know what I mean?
Yeah, that's really good to think about. Those aren't, I think when I first think about NAT, I'm thinking about injuries.
That's right.
But development is certainly an indicator of neglect or abuse, and won't jump out at you like a bruise from the belt would. But like you're pointing out, that's a red flag itself, and just it takes a little more experience and imagination to put those two together.
So in my experience, as an attending or whatever, the cases that are most commonly missed by residents, probably by myself too, I just don't catch my own misses that much. This baby was kind of an hopefully unusual example of missing a concern for NAT, but are neglect cases. So I've had multiple cases where a baby comes in for a runny nose or a fever or whatever like that. And in emergency medicine, especially, we're very chief complaint focused. They're here for a runny nose. I went and saw them for a runny nose. They have a runny nose. They don't have an ear infection. I'm going to discharge the patient, and we become very mission focused. And sometimes that leads us to miss things. And most NAT, you're probably not going to miss, or at least a lot of NAT, you're not, it's a little bit more. The neglect stuff, though, is very easy to miss. And I've had multiple cases of starving children that came in for runny nose. The resident didn't come back, tell me runny nose, I'm going to discharge the patient, and I go see them. And you walk into the room and you're like, they've got they look like Starvin Marvin from Ethiopia. They got temporal wasting, and they're super sickly looking. And I can remember a case of a kid like that I walked in and I was like, well, they might have a cold, but they also, are starving to death. And anyway, the kid has rickets and scurvy, and the parents had only been giving the kid mashed potato from Church Chicken or something, some restaurant. And
Church's Chicken.
Yeah, that one. And so I never been, and especially after this case. And Hawaiian Punch, coding, and we got them back. They coded on the floor because they started a dextrose drip on them. And
refeeding syndrome?
Wow. Yes. And ended up having to get bilateral cornea transplants because they would have been blind otherwise with all of their scurvy, and they had vitamin A deficiency, vitamin C. So anyway, point is that kid was like on the rack for discharge. So
Wow.
It's it's important that I know that like and I do it the same as everybody else. We're very like mission focused and chief complaint focused, but um, it is good to kind of have a little suspicion when you walk in the rooms and just to have an idea. Does this 6 month old look like a 6 month old or 12 month old look like a 12 month old? Um, and actually, in your computer system here, it's nice because there's a growth chart tab on the side that's actually really easy to access. Have you used it? You know where it is at?
You know, I just learned about it from another one of these videos that Armin
Okay.
Valdez did, where he pointed that out, and I was totally unaware of it before. But so can you mention it though for those who haven't seen that video?
Yeah, so I'm not a computer person, so you're gonna have to forgive me, but you probably could know where it is better than I am. But it's like on that left side
Yeah,
there.
yeah.
When you go down, there's one that says growth chart.
Hmm.
And if you click on that, it'll pull up all the tables like height, length, weight for length, BMI, all of them.
Right, perfect. Yeah. Yeah, I mean, in El Paso, I think we do see a lot of patients who are there for one visit. And, you know, in other places where patients are more plugged into the community, that issue isn't as big of a problem. But patients who come from Mexico, or who are kind of living in without much follow-up care for whatever reason, you know, you could make the difference. So that's a really, really good case.
We talked about military families.
Mm-hmm.
The other thing to talk about in Texas, and at A&M, I saw more child abuse in Texas over the years than I ever saw in Philadelphia, ever. And we had, you know, child abuse doctor that I really liked. He was one of our PICU docs who had kind of retired from the PICU. But anyway, and I said, what the hell is going on around? You know, these are all supposedly sort of upstanding, you know, Christian, you know, I love everybody. People, what the hell are they doing, you know, with their kids like this? And he called it the Bubba factor. And what he meant wasn't that you're a Bubba necessarily. What he meant was that people in rural Texas, they live a lot, you know, not in El Paso necessarily, but people maybe even you see from New Mexico coming. They live in the middle of BFE, you know, and then there's nobody around, you know, they may live on a ranch or a farm or whatever, and there's nobody around to see what they do. And they develop odd sort of asocial belief systems about things sometimes. And so, you know, same thing. I can't tell you how many cases I saw of kids with the most bizarre things that were from like a farmer or rancher in the middle of nowhere who was homeschooling their kids. And so there was no, like you were talking about, there wasn't like a social setting to pick things up. And because they were very, I guess, nuclear in their family or whatever, they sort of, a strange idea maybe could propagate and turn into something bizarre. There was a kid I had who also coded. It scared the crap out of me. He was like 14 and he was like 30 kilograms. And he came in
Wow.
for something minor, like I don't know what he came in for, but he hadn't been to a doctor. I don't know what made them come in that day. But he, I think, had developed an eating disorder and then got depressed. They lived in BFE, homeschool, blah, blah, blah. Well, he wouldn't come out of his room for a year and stopped eating. And the family just thought he was being defiant, you know, and so they would leave food, but if he didn't eat it, they just chuck it out or whatever like that. And so he hadn't seen the sun like in a year, you know, and had been in this room not eating or whatever. And the nurse stood him up in triage and he coded just from standing up in triage. It was crazy. He had a horrible active, you know, cardiomyopathy, everything. He ended up living and doing okay. And it's an interesting case because the parents had no idea that this was weird, you know. But then after we took care of him at the ER, then he was in our PICU forever. But afterwards, when it was pointed out to them that how odd this was, and that something probably should have been done earlier, and they were the most grateful parents you could. I got the nicest. The father came down. He wrote a letter and everything, but he came down and was giving me giant hugs and everything. So you would think this family was sort of awful or evil or something. They weren't. They were just kind of dumb and like weird, but loving weird and dumb. And so once it was like pointed out to them, they were super appreciative. So that's the other thing about when you see cases like this, you don't always, you might think like these are the worst parents in the world, but they made a mistake, but they weren't horrible people by any stretch.
Yeah, but certainly kind of like a paradoxical behavior there, the contrast between the gratefulness and
it was weird.
Basis was so bizarre. Yeah.
The whole thing was weird, but it ended okay. So that's good.
Good. Okay, well, so we've talked about some red flags. We've talked about the textbook classic thinking. Let's talk about things that can lead you astray, that you can misconstrue for child abuse that usually aren't. And I think the easiest one, the one we might see on the boards, is a toddler's fracture, that spiral fracture of the tibia. That's pretty well known for not being child abuse, and it's a common injury. Any others come to mind?
Very common. And the thing with spiral fractures is, I don't know where this idea came in that spiral fractures equal abuse, because they really don't. You see spiral fractures, not just toddler fracture, but other spiral fractures frequently. So spiral fractures, they are what they are. And you just need to listen to the story and put it into context, like we talked about before. Fractures that I get very concerned about, though, that we'll talk about later, are corner and bucket handle metaphyseal fractures. Those are pretty darn specific for abuse.
Okay.
And so, not always, but they should definitely raise the hairs on the back of your neck. So a couple like abuse mimics, or either parents come in, or like you get transfers from outside hospital or whatever, concerned about abuse. So the big one is like a 5-year-old girl with vulvovaginitis. And the parents are concerned that she's itching down there, or she's touching herself, or she's red, or whatever like that. And girls at the age don't have great wiping skills yet after they go to the bathroom, and they get irritation and schmeggies down there or whatever, and that's like normal. So while it's reasonable to get a urine and maybe send the urine for GC chlamydia and whatever, but if there aren't other red flags and it looks like vulvovaginitis, I kind of end the workup there. Straddle injuries are another big one. Sometimes I think that we're probably here and at UMC and everything are familiar with straddle injuries, but you'll see a lot of tiny little hospital, middle of nowhere, and it's alarming, and parents are alarmed by them too, and sometimes they're unwitnessed. Normal bruising patterns. So little kids who are super active and whatever, their legs are like covered in bruises, and the other thing to remember is that, like, when you first start walking, for a while, you're not like,
not very good at it.
Yeah, you're terrible. So falling and like, I feel like some like, especially active kids, like live there from like 2.5 to 5 with a constant like on the front of their head from running into crap all the time. Like, that's normal. So like we said before, like bruising behind the ears and all of that, that's not normal. But little toddler running into stuff and smacking his head is normal. And there's a couple other things. folk treatments sometimes can mislead you. I don't know what the folk treatments are here exactly. I something about rubbing an egg on people, or it seems to be a lot of food product folk treatment here. I don't like mustard on wounds and all sorts of. So that doesn't usually look like abuse, but other places you'll see like cupping and stuff like that.
Mm-hmm.
And and so there are folk treatments that can. Do you know if there's a folk treatment? I don't know.
I think chamomile tea, like you said, it's a food thing. I don't know any others that are like mimics of abuse, but that one I've heard of a lot.
Yeah. Uh, Tinea capitis can like a nasty carry-on. I've
Yeah.
seen.
Yeah, well, you included that image of carry-on
Yeah.
in some of the materials you sent me.
And remember, they're lumpy. You know, if you don't know what you're looking at, people can think that they're like bruising or hematoma.
Hematoma, yeah. Okay. Okay.
So
Nice.
there's like a million mimics, but those are some of my favorites.
Cool. Yeah. Good to know.
And
besides the skeletal survey, what do we need to get?
Yeah,
right. That's
a skeletal survey.
Okay.
So often there's a concern for brain imaging, and so if you have like a kid who's not neurologically normal, or you're very, very concerned, obviously a head CT would be the thing to do. You can in infants who you're not necessarily super concerned about, just remember they still got a hole in their head, and so you can get an ultrasound of their head too.
Okay. So can you talk a little bit more about that? You're talking about the cranial ultrasound, and that's through the fontanelle?
Yes.
Okay.
And so, we use them like in the NICU all the time for intraventricular hemorrhage in infants. Sorry, they decided to start playing. Anyway, we use them all the time in infants for IVH, but you can use them. So I don't do a cranial ultrasound in a suspected NAT case if I'm concerned they are likely to have something in their head, or if they're neurologically abnormal or anything like that. But if it's more of a screening thing, I will sometimes do it just to avoid radiation.
So what question can we answer? We can say, is there ventricular hemorrhage?
Well, you can ultrasound. You can see you can see blood anywhere in there.
Okay.
You can see and stuff like that.
Okay.
If they're young enough and you get good images. The other thing is lab workup, and most of it's obvious. The thing is to remember, we always get LFTs in these kids because a lot of time, we're not pan scanning a 4-week-old, hopefully, most of the time. But if they've had liver bleed or whatever, you'll see a bump in their LFTs. So we like to look at that. Similarly, you can see a bumped amylase and small bowel injury. And then for sexual abuse, remember that you can always do PCRs on their urine as well. And the last thing, father in the ER sending osteogenesis imperfecta studies. But if you have a kid with multiple fractures, for medical legal reasons, that probably will send OI, or often will send OI studies from upstairs.
Okay, good to be aware of that. Another common mimic we didn't talk about, but a good board exam question.
The boards or whatever.
Yeah, exactly. The blue sclera.
Remember, blue sclera is only a small subset of all types of OI. Okay.
So, do you want to talk about some of those images in particular?
Yeah. So first, I wanted to talk about the metaphyseal fractures. So those will be the bucket handle slide and the sort of healing bucket handle slide and the corner slide. And so they're kind of obvious why they're called that. And it used to be theorized that there was a different mechanism for a corner fracture versus a bucket handle fracture. But it's actually, it's the same injury. And and how it appears on the X-ray is dependent on the projection. So you can see something looks like a corner fracture, then another view looks like more like a bucket handle fracture, but it's the same thing. And so these fractures are caused by like multiple metaphyseal microfractures, and they're caused by loading on the bone in a shear fashion perpendicular to the long axis of the bone. So I don't have a doll, but here, come here. So you get the kid and they take their arm, shake it back and forth, and same with the leg. So, sorry, Dexter. Shaking. And these are very common. So the skeletal survey, when you get it, has 1 million images on it, and they're hard to read. But my money shots on the skeletal survey are going to be your elbow and your knees, especially, but honestly, any of the joints. And the first thing I'll do is look at those images for these metaphyseal fractures. So I think around half, 50% or so of patients with NAT will have bucket handle or corner fractures. So it's a huge number of these cases. You're going to see that, and it's not 100%, but it's almost pathognomonic for NAT. Any femoral fracture in a non-weight bearing infant, unless they have OI, is NAT. Like that is pathognomonic for NAT. So you can be confident in saying it's NAT if they don't have OI and and they have a bunch of femoral bucket handle fractures. And we mostly see these in under 2-year-olds.
Okay. So we'll make sure to overlay the images, the bucket handle and corner fracture here.
And then the next images, I just thought it would be good to throw up, were the periosteal reaction images.
Okay.
A little bit more subtle, and I think I have 2 images of those.
Yeah, walk us through those.
Yeah, so basically, this is obviously it's bone healing from an aged fracture, and these can be a little bit subtle, and you can miss them easily. But so after I look on a skeletal survey, when I'm looking at them, after I look at the joints, then I'll look. Usually I'll look at the long bone periosteum. So, fib, femur, arms, and you look to the sides and you can see there's like an arrow on the one image. I think it looks fuzzy to me. That's how it looks to me, and not nice and crisp. The thing is, if you see that and that's it's good to talk to your radiologist about it and maybe get additional projections, because sometimes it can just be the projection of the image. But if you see it in multiple projections on the side like that kind of rim of fuzziness, that's suspicious that they have like a periosteal reaction there. And there are some more images I put of rib fracture. So that's usually where I go next. When I look at a skeletal survey, and the rib fractures, the images there are pretty obvious because they're healing, and they look like calluses, or like little knobs or buttons or something.
So we have the AP chest image here, kind of.
You see that there?
Mm-hmm. Mm-hmm.
And I have more images if anybody wants to see them. But anyway, the thing about rib fractures is CPR, you can definitely get rib fractures from, not all the time, but sometimes, but they're anterior rib fractures. So posterior rib fractures are always abnormal and always concerning for NAT. Mm-hmm. And they'll get these rib fractures frequently from being shaken. So I'm sorry. they're so mouthy. Come here. Okay. So the parents will grab the kid, and shake them back and forth, and like their little fingers or thumbs or whatever would just squeeze the crap out of them and break their ribs posteriorly. And so if you see posterior rib fractures, that's also abusive in the absence of OI. And usually because the rib fractures are another money shot on these osteosurveys, you'll have like an AP or a PA view, but then they'll have rib views on either side, which is helpful to look at. And remember, if you see rib fractures, especially lower rib fractures, you need to have a high index of suspicion for intra-abdominal trauma.
Okay.
So if you're seeing them, you really need to check their LFTs and maybe get an abdominal ultrasound too, to make sure their liver is okay and everything.
Yeah, we usually don't get those rib-specific X-rays on the adult side, and that's a good thing to know that you can do for kids.
It's like useless and most of the time, and except in this setting.
Mm-hmm.
So I wanted to pull up the posterior falx subdural.
Okay.
I just like this one because obviously it's pretty obvious if you have a regular subdural or an epidural hematoma or something. I don't think that you're going to miss that on the CT scan when you're looking at it. These falcine subdurals though can be tricky, and so I would just pay attention. You can see in the posterior falx there. You can compare it anteriorly and everything, and you see how it's a little bit thicker and more enhancing. And so when you're quickly scanning through a head CT, like I said, I don't think we really miss most bleeds. I think we're all pretty good at finding bleeds, but this is just one area that I would pay attention to and suspected NAT to make sure you don't miss. They're often associated with shaking injuries as well. And so, and I don't think that in most trauma cases, like regular trauma cases, from your ATV or whatever, we're not usually super worried about falcine subdural so much. I don't think that's like super duper common to be a lone injury, or a lone lesion on a CT of the head in most of our accidental traumas. So I would just pay attention to the posterior brain and make sure you don't miss it. First pattern image is the one of the back that has a bunch of different, it looks like they were electrical cord whipping and some bruising there. And I just thought it was a good example of God doesn't make right angles.
Right.
And so, if you can, and it's intuitive when you look at it, but it's just good to think about the fact that those are patterned injuries. And there's some patterns that can be a bit confusing. So I have 3 images of bites. And so with bite injuries, first of all, they're actually like way more common than you would think. I don't know why people bite their children so much. It's simply an odd thing to do. But anyway, they're actually super common. Most of the time when you see bite injuries, someone will try to say that it was a kid at daycare or something like that. And sometimes, I don't know, maybe it is. But the forensic nurse and whatever, they can measure them and do all of that business. That's usually too fancy schmancy for me. But with the bites, they can be very confusing. So you can have animal bites from neglect. So an infant is actually fairly easily bled out from being in a crib bitten by a rat, which happens not infrequently. And so it's actually a pretty common thing that you may very well see an infant left alone in a crib for too long and a rat got in there and they'll eat them. They'll just bite. And if no one pays attention to the crying or whatever, they'll hemorrhage out and they'll just be found in a pool of blood. So just think about animal bites, and even if it is an animal bite, is it related to neglect? And then for human bites, they can look, because hopefully most of us are not perverted enough to think about going around biting people all the time. So it's not like, so when you see it coming into the ER, you're like, your mind doesn't immediately go to someone who's been biting. And so I've seen lots of cases. I've seen a case of a kid who was diagnosed with erythema multiforme, but really it was a bunch of bites. So people can be easily thrown off by biting and bite injuries, and they'll look different depending on their age and how much force was involved, if there's bruising, not bruising. But and then facial bites, I think I have a facial bite picture in there too. And like I said, they can look like a rash. And those pictures are a little bit more obvious, but they can be subtle. And facial biting is popular for some reason. I don't know why. Have you seen biting?
No, I can't say I have.
I don't know why people get into biting like that. It's really strange to me.
Yeah, yeah.
And then the last one were carry-ons.
Okay.
So, this is like tinea capitis gone horribly wrong. And it's pretty common. People may think that because it's so lumpy and nasty, it's either abscesses, like they've been neglecting the kid and they have a million abscesses, or that it's bruising or hematoma. But it's really just having in the back of your mind, it could be carry-on. It's most common in African American male children. Remember, if you're treating carry-on or whatever, or frankly, even tinea capitis, don't bother with creams. Like, honestly, they need oral griseofulvin for like 2 months, because otherwise it'll never go away. Don't discharge them on cream. And those were most of the pictures. I'm trying to see. There were a couple other stuff. Oh, the one mimic I forgot to mention was Mongolian spots.
Oh, okay.
There was a slide you had about red flag injuries.
Okay.
And so I just, I think we touched on it briefly, but like kids under 2, especially non-weight bearing kids with any long bone fractures, you should at least think about it. Think about NAT or abuse, especially in the femur.
Mm-hmm.
And then, like you said, oropharyngeal trauma, abdominal trauma in young children. And then there's a bunch of weird shit. So we talked about bites. Pinch marks is another one. Sometimes they go hand in hand. For some reason, biters also like to be pinchers. I don't get. And you know what else I've noticed is that I don't have data on this, but I feel like I've seen much more biting and pinching with mothers.
Mothers as the abuser, then okay.
Yeah. I don't know why. It's weird. Cigarette burns can look funny, especially when they're healing. Just have a little. So sometimes they'll look almost like nasty bug bites, or something weird like that. And then immersion injuries is another one to think about. So
that's the classic. Yeah.
And so kids all the time pull hot stuff onto themselves, and the vast majority of the time it's not NAT. But God doesn't create right angles or lines, really. So if you see a burn with a nice linear pattern and then it stops, definitely think about like an immersion type injury. Yeah. And that, like the picture that was up there, rope and electrical cord injuries are also very popular nowadays for some reason. And they sometimes you'll see like a electrical cord injury and it's actually a laceration.
Oh, okay.
This was the most disturbing conversation. Next
I was
time
gonna say, yeah,
talk about happier things.
let's do that. I was gonna say, you know, I was really enjoying this conversation. I think there's a lot of brilliant insights. However, I can't say I enjoyed it when we talk about infants being eaten to death by rats. Talk about a gruesome image. Oh my God. Yeah, well, such is our job.
Exactly, exactly. So next time, Witcher, we're going to talk about puppies and kittens or
Let's
something.
talk about puppies. Yeah, good deal. All right. Well, thank you again, Dr. Stern. It's been a pleasure. Let's wrap it up from there and hope to talk to you about more stuff in the future.
Sounds good, dude.
Thank you so much.